is an interview with Dr. Jacqueline Perry, P-E-R-R-Y, in her office in Building 304 at Rancho Los Amigos Medical Center in Downey. The date is November 5th, 1985, and the interviewer is Colleen Adair Fliedner.
Well, my first degree was in physical education, and that was really a compromise. I don't know. I have no reason why I wanted to be a doctor, but ever since I was a child, I wanted to get into medicine, and I'd even just like the looks of hospitals, and I'd see all the movies that had hospitals in them, and it was just one of those spontaneous things. There's no one in my family that's in medicine, except two extremely remote cousins that I may have met once in my life, and that was it. Anyhow, so I went to college, had a math major just because I wanted to go to college and had to have something. Then I went into physical education because I liked the science and I liked sports, and that was a good compromise. And then from there I became aware of physical therapy, and so I went into physical therapy. Conveniently, the Army started a school. Actually, it had a school, but they put it on civil service that time, so I heard about it by announcement, so I applied and got in there. So I was in the Army for 5.5 years, a physical therapist, and that was a great time because throughout World War II, and so I had tremendous experience of, I did everything in physical therapy in 5 years.
Did you serve here or overseas?
Well, I was mainly here because I got involved in teaching, and so I was at two different. They started 6 additional schools of physical therapy because the Army had its own physical therapy school, and then they started 6 additional ones in different general hospitals to meet the need for World War II needs, because there weren't very many schools of physical therapy at that time. And I was in sequence at 2 different hospitals, one down in Hot Springs and the other one at Fitzsimmons as far as schools, but I was in the end. So then I, in the course of that, became very interested in orthopedics. And then the GI Bill materialized as part of the the inducements for people in the service, and as a reward for the service, I guess. And so then I took advantage of that and went to medical school with the intent of becoming an orthopedist.
And that would have been then right after the war?
Yes, I got out of the Army. Well, I was late getting out of the Army because I'd been in these schools all this time, and the only overseas duty I had was down in Puerto Rico for 2 months, and that was the end of the war. And while I was down there, then they suddenly eliminated all this point system. They determined priorities of getting out. And points were earned by overseas, both longevity of service, but primarily overseas service. So mine being all in the States, my score was dismal. But then they suddenly decided they wanted to discharge everybody. And so the points disappeared, and so I got out as fast as I could so I could go to medical school and use the GI Bill. And so I got out on I'll tell you a funny side story, just pure bureaucracy. I was in Puerto Rico, and knowing that I was going to get out, I applied to UCLA for admission in the graduate school. Because I had a degree, I had to go to graduate school. But I wanted to take undergraduate courses to finish pre-med requirements. So anyhow, I wrote from Puerto Rico to Southern California. And they said, well, you have to apply to graduate school. I decided it. So then I wrote another letter to the graduate school. And of course, it was down the hall, you understand. And finally, I got this all mechanics straightened out. And then they said, well, you're taking undergraduate courses, so you don't need to work through the graduate school. But through all that bureaucracy, I got out 2 weeks before school started, and I got in admitted, and so I went up to the discharge area the next week, and then I went to school. So I just barely got out in time for the spring semester, and so I made up various credits necessary for med school by that summer and that spring semester, and then a double summer session, and went to medical school that fall.
Where'd you go to medical school?
University of California in San Francisco. Berkeley, actually, at the time.
And you were specializing then in...
Well, no, you just go into medicine.
You just
so
medicine?
You just medicine and get an MD. And so that... But in the course of that, I became very interested in that particular orthopedic department because they do a lot of biomechanics and things like that. So. And conveniently, I was able to get in there. I applied several other places, but at that time they weren't very interested in women, and so quite a few of the schools said they didn't even take women. But University of California was favorable to women two ways. First of all, one of their main donors when the school first started way back in 18 whatever was a woman, and so there was always a stipulation to take a certain number of people in medical school as women. In fact, about 10% of the people practicing in San Francisco are women, and have always been, for that reason. And then they'd had one woman complete her orthopedic training prior to me, and she was an excellent, left a superb image to follow. And then they had a couple other people go part way through, and then shift off into physical medicine because it was easier. So they'd already had accepted women, so anyhow, on that basis, I guess I got in. I didn't really care what the basis was. I got in. I got what I wanted. And so I finished my residency in San Francisco. And one of my classmates was Vernon Nickel's brother, Eldon. And so I met Eldon, and I was not particularly interested in the private practice of medicine. I'm not much of a business person. In fact, I think I specialize in avoiding money, but that's all right. And so I became aware of Rancho, and he was looking for somebody to help him.
To help his brother, or to help his...
Well, see, Vernon Nickel, who was here.
Yeah.
I don't know how much you know about, but anyhow, Vernon Nickel was the orthopedist running the program here, and he was doing it by himself, and he was also in full-time practice, and so he was terribly busy, and the program had become very large because polio was at its peak, and so he wanted some help, and that's exactly the kind of thing I wanted to do, so it wasn't very hard to get along.
So you met him through his brother.
I met him through his brother, and I knew him for about 3 years, so when this came up, then he sort of sought me out. And not being interested in money was very practical because they didn't bother paying much money at that time.
Wonderful. So that would have been in about 55 that you...
That was 55 I came here.
You came here. So you came specifically then to help Dr. Nickel and...
Specifically because of the polio, of the orthopedic kind of program they had here. It was exactly the kind of program I liked. At the time I came, Rancho, the active program was purely polio. And John Appelt was the medical director. And Vernon Nickel was head of the orthopedic program. And I was the other orthopedist.
Just the two of you?
Just the two of us. Okay. And we had 2 orthopedic residents. And who initially came for 6 months, and later we extended it to 9 months, because that was really their major time for directed teaching and reconstruction. We had the load, and they had the desire to learn, so it worked out fine.
What did you do then? What types of things did you do for the patients?
Well, we had there were basically 3 programs with patients. One is physical therapy and occupational therapy, in order to therapy program to develop function. Another was an orthotic program to give them the right braces, and we did a lot of work on designing new braces. We had some very creative orthotists, and one was Jack Conry, and another was Roy Snelson, and they did a great deal of creative work. And then we had reconstructive surgery, and one of the main developments of Rancho in the surgery area, there are probably 2, but one was developing a system to operate on the respiratory dependent patient. And, it was assumed that these people couldn't tolerate surgery. On the other hand, if they had a kidney stone, there was a great deal of furor to get appropriate respiratory coverage, and they got their stone operated on. And if they had babies, they got deliveries, and if they had appendicitis, they got operated. Well, if you can do it on an emergency basis, you certainly can do it on an elective basis, because you can just plan ahead. And so we used the same techniques, and Vernon had started this before I came, but they just expanded it. And with excellent support from the respiratory physicians, of course, they really made it happen. We just used the same plan, and all we really had to do was develop some better techniques and greater concerns of getting the patient from the ward to the surgery, and then during the period of induction, making sure there weren't any, they were constantly monitored, which you don't have to monitor a normal person that closely, so you just had to set up a higher level of concern and watching, and we had no problems. And no, we operate on. I don't know how. I've probably operated about 5,000 people that way, and I haven't operated on all of them, but I meant the surgery program itself, because we had. Well, I think we've had about that many go through surgery, and most of them were respiratory dependent, because that was the kind of patient. The Rancho specialized in the severely disabled. The history of it, which others probably give you too, is it started out with the custodial center, and you know the basic route. And one of the problems they had in the polio is that they had these patients in respirators, and the respiratory program in the acute hospital down in the medical center was a contagious disease unit. Well, you can't have braces, and you can't have anything that you can't burn, destroy, because you don't want to carry infection. And so they couldn't have adequate long-term care, and they discovered these patients were staying in respirators because they had permanent respiratory paralysis or major respiratory paralysis, and so they developed a respiratory center here over in the 70 building. Now that's before I came, and by the time I came, they just moved the year before in the 500 building. But that was the basis of finding a place to house all these people. And then John Affeldt came and developed a therapeutic program for the respiratory patient to get people out of the respirators. Before that, they had a less intense program. I mean, of course, some people got out of respirators, the therapists worked with them, and Dr. Dale worked with them. But the really aggressive respiratory program came and started when John Affeldt came. And then he noticed all these people are stiff and deformed and couldn't function very well, and he enticed Vernon Nickel to come in as a surgeon who he was one of his classmates who was in practice here in Downey, which is a nice tie. And they had orthopedic consultants, but there was so little you could do on just a come-and-go basis. One orthopedist was from Torrance, another one was from Pasadena, and they didn't have much opportunity to do much, because you can't do very much if you aren't around to watch for complications and things like that. So it was a very, very meager program until Vernon came.
It sounds like that when he came, and also when you came, this was kind of a new thing. It was virgin territory, so to speak. Did you have to decide to look at a patient and come up with something new for this patient, or was this being done?
Well, the procedures. We developed a few new procedures. Basically, the procedures weren't new. I mean, they were. Spine fusion had been done on people with crooked backs since 1911, when Hibbs and Albee got it started. But because not all spine deformities relate from polio, because we still have them and polio's gone. There are just spines that don't grow straight. I mean, there's a growth is a tremendously complicated mechanical and chemical and physiological event. You just sort of wonder why anybody grows straight, to tell you the truth. And it all comes out right for 99% of the people, but some people have problems, and so there have always been orthopedic programs for these people. What we had to do is develop ways to do it on people who had breathing problems or are more fragile on average, just because they had more paralysis, and so we modified, standard techniques to meet this new demand. And one of the major developments in that direction was developing the halo. And the history of that is that Vernon Nickel was at a meeting, and somebody at a polio meeting actually was showing a frame that they used for facial maxillary injuries during World War II, which sort of screwed to your head. And so he said, that's what we need for our fusions, because before that we were just using some wires put in the skull, and they didn't give you much control. We'd done 2 patients with wires, which you see was an adaptation from when a person breaks their neck, you have to put traction on the head, and they had what they call Crutchfield tongs, which are like a pair of ice tongs that you sort of caught the head with. Well, those tend to slip, and so that there were some loops of wire made through burr holes in the skull called hone wires, H-O-E-N. The man's name was H-O-E-N. And so I had experience with those when I was a resident, just by pure chance, but that was a technique I knew about. So we tried those, which are more secure than the tongs, but they still didn't give you, 2 points fixation. They didn't give you all three-dimensional control, and so we were still caught. Well, this frame looked great, and so we tried it, and first thing we did was break it because it was not a complete ring, and so we made a complete ring, and so Vernon Nickel brought that back, so he's really the starter of the halo. But I'm the person that put the first one on because I did most of the surgery. And once I came here, I was the surgeon because I was here full-time and he was here part-time. He was still a busy practitioner, so I did the majority of the surgery. And so that, so in that sense, it was a dual development. That was his idea, and he brought it back. And that has been a major contribution to orthopedics. It's now the standard means of handling neck fractures and major spine deformities in the upper spine and neck, because you can get a hold of the head. And you can't, otherwise you really can't, because the chin doesn't have much fat on it, and therefore the skin's easily injured by pressure. If you put casts around, and people have an old habit, they like to eat, they like to talk, and if you leave the jaw loose to eat and talk, then you have no hold of the head, really. And you can't get a strap around the forehead very well, and so the halo was just a real and it didn't slip like the tongs, and it's now the standard device. You go to the orthopedic meetings now, and that's all you see on display, and you'll see 8 companies with different variations of the same theme. They got a little different jacket, because now most of them go on vests rather than on casts, and they've got different uprights, and they got different pins, but
basic thing.
They're all the same thing. Yeah, that's right. And so that's now become the way of handling cervical injuries and any extensive surgery of the neck.
Do you recall when that would have been when you did that?
Yeah, it was 1950. That was late 55 and 56. He went to a meeting probably. I arrived in July, and he probably went to a meeting in October or something like that.
So you've been doing that then. Right off the bat,
so we got involved in that right away,
and
it was just one of those, we put to work right away because it's obvious an answer. And then we found out that Vernon Nickel's partner Neufeld, who's a clever man, had one in his garage too, but he didn't tell us about it. We didn't have to talk about the needs, and because he. During World War II, they had all these problems, these massive burns or facial injuries, and they had to want to put traction on to get the bones back out. That's what the original design was.
One of the reasons I was asking you about the new techniques was I think it was Dr. Barris that said that you would look at the hands of the polios and then try to decide what kind of muscle transfer.
Oh yeah, we did a lot of that.
But you tell me about that. I don't understand it.
Well. I don't understand. They're basically 4 sets of muscles. There's some small muscles which give you the rotation and the control of this first joint. There's another set of muscles that controls that joint, and another set of muscles that controls that joint. And then you have a set of muscles that straightens out your fingers. The normal person, and polios have normal control and normal sensation, which makes them unique from anyone else other than a person who's had an injury. I mean, they're from all the other kind. In other words, different from strokes or spinal injury, which have these other problems. So they're more like the normal person, but instead of having an injury, they had a paralysis. And so the hand has, it's tremendously versatile structures, but there's some basic requirements, and basically the most important thing is to get your thumb and first and index finger together. And as Vernon Nickel would say, his grandfather only had 3 teeth, and they met, and that's what made him could chew without. But anyhow, so we wanted those to meet. And the other is this gross grasp. And if you had to make a choice, you'd really take the pinch. And so when a person has, from polio, they would lose some muscles, but not all, in many instances. A very severe one might do. But a lot of them just would lose one set or the other, or some mixture. They'd lose, and so you'd look at, you knew it was normal. And anatomy happened to be my hobby, so that helped. And it always has been, and I'm still teaching it. And so you'd look at what they had, you look at what was normal, and you look at what the essential functions were, and then you'd figure out what you could then you knew about how far you could move things, what anatomy would allow, because you have to maintain the nerve supply and the blood supply, so you're sort of moving the end of a leash around, and you just rearrange things to figure out what you had, and you have wrist muscles. There are 3 muscles on the front side and 3 muscles on the back, and you just figure out how you could borrow these muscles, sort of rob Peter to pay Paul, and make sure that Peter could spare it. And so you had to maintain the essentials, but take off, but you could borrow the surplus if you, and come down to the minimum basic function. And you do that also for the elbow, and you do it around the foot. But the hand, of course, is most intriguing.
Yeah, it's because of the grasp.
Yeah, and the hand, a person without a hand is a terribly disabled person. Historically, it's been interesting because everyone recognized you needed a foot because you couldn't walk without a foot. And there are a lot of things you can do one-handed, so the hand sort of got less respect. But you have to have at least one useful hand. If you don't, then you can't eat, you can't dress, that's in big trouble. And so we used to, and so we had a lot of, we just, so a lot of those kind of procedures were, that type of procedure was creative,
You wrote an article or co-wrote an article on hand splints, and I hadn't been able to find that article. But when you say hand splints, is this what you're talking about, or is that just an outside apparatus?
No, that's an outside apparatus.
Uh-huh.
It's the original hand splints were actually designed at Warm Springs, one type, and there's another type that's developed up in San Francisco. It was pretty. There's a lot of them when I was resident intern. Then we just sort of built from those plans and did a lot of original things. And if you look back in history, you can always find a model was done by somebody sometime. Like what we're known for is a flexor hinge hand splint. We bring your wrist up, you bring your fingers together. Well, the original model was by Bisgrove in 1900 or who knows when. But it was a cumbersome device, and so with clever orthotists like this Jack Connery I mentioned, we just they made sure that the thumb and fingers really met. The initial idea was to have everything very mobile, like the flexible hand, but then if it meets over here, it doesn't quite meet, and it isn't very good. And so we just refined the mechanics, refined the functional principles, and made it work. And then a lot of them we could reproduce surgically. We could put a bone block across here, take tendons, and put them tight there so they'd meet like that.
That's what I learned.
Yeah.
And you say it was developed at Warm Springs?
Well, that wasn't. No, but Warm Springs had some hand splints. They had simple splints. They used a lot of rubber bands and springs, but Warm Springs Warm Springs was the first polio center. And it started, I've learned a lot about the history. My current specialty is the worn-out adult polio, because they've used these muscles too intensely for 30 years, and they're wearing out prematurely. And so that's I'm back on polio again. But what I've learned is, so we're now the polio center of the country, and of course Warm Springs there too, but one of these, because we've always had polio, and I'm still active in polio. I'm probably the only physician, I think, in practice that was active in the polio era, so I get quite a few people from all over. And I've met some of these people who had polio 60 years ago. Yeah, 85, 20, yeah. 1918, 1920, 23. And no one knew about polio then either. And I didn't realize how big a contribution Roosevelt made until now. And because they didn't know what to do. They were paralyzed, but they didn't know what to expect. There were all sorts of theories. And so some got intense treatment, some didn't get much treatment at all. Pain went away after a few weeks. With this inflamed muscle business went away. And so then they were just sort of left on their own devices. So that Roosevelt stimulated the Polio Foundation, which was a source of money to treat patients, and developed Warm Springs, Georgia, because water is a lovely place for polios. It's nice and warm, and it allows them to do things. So it makes them comfortable, and it lets them some exercise that they couldn't do otherwise. You can do it. Actually, most of us got away from the water business because the water that's warm enough for a patient is too hot for the staff, and you die. It's very, very fatiguing. As a physical therapist, I was in Hot Springs where they had all these. Hot Springs, Arkansas, was the polio center for the Army, and I was there for about a couple of years, I guess, 2.5, something like that. And so I used to be in the pool, and you just half days all you could stand, because you can imagine being in water that's 95 degrees temperature, and your normal skin temperature is 92.
It'll be hard on you after a while.
And to stay there all morning from 9 to 12 or something, it's enough of that. You're just exhausted. And you can do the same thing with springs on dry land, but it's just not as fun. But you had the pools, and so that was, it's great. And it allows patients to do things you couldn't do otherwise. Although I also did not like them because it falsely implied the patients could do things they couldn't, and I thought it raised false hopes. Because you can walk in the water, and then as you get the water too shallow, you can't walk, and then it sort of gets you dreaming falsely instead of meeting the fact that you're going to have to use braces and you're going to have to use crutches, and that's life. And I sort of believe in facing life as it comes. And
well, so you're back, and are you doing research on these muscles now that are giving these people problems?
Well, the research we're doing here in the laboratory is recording their muscle function to see what patterns of muscle function, and try to document why we see these different substitution patterns and why things are wearing out. But, the basic research that has to be done is the research of the physiology, the maintenance physiology of the muscle. There's all sorts of muscle physiology, muscle study, the research. But it's following two patterns. Either it's to try and look at why they degenerate, like muscular dystrophy, which is the original, or they're looking at the contraction, the strength, force capabilities of muscles, sensitive towards athletic kinds of things. But you don't read much on what a muscle does to keep itself healthy from day to day. For instance, in the heart, we have digitalis, which takes a disabled heart and keeps it going. We need something like that for skeleton, for the leg muscles, but we don't have it. Or maybe there's nothing to do with it, if the repair system doesn't persist anymore. But basically, it's an overdoing phenomenon, I think, and I've been documenting the correlation between what they had when they had polio way back when and what they have now, and made it very clear that it's only the ex-polio muscles that are in trouble. It's not new polio. It's not attacking a normal muscle. So that it's a little bit historical rather than factual, in the sense we don't have the old records. Because I haven't really tried to send for old records. Most places haven't kept them, and because you only have to keep records 5 years.
Oh, then they shred them, don't they?
Yeah, and well, otherwise you're just inundated. We have some, but most of our patients haven't come back yet, because it takes about 30 years for the muscles to wear out. Well, our peak activity was 52 and 55, and so we're just in the 30 year, and I've seen a couple of patients.
So do you expect this will then increase then?
For a while, and then I think it'll level off, because the vaccine stopped polio in 1955, and so that there's going to be an end to how many people you have, but there's going to be a population for a while.
Going back then into we were talking about, say, the late 50s, and then with the polio people and the vaccine, I realized you still had a lot of polio patients here that you were rehabilitating and putting the braces on. But at that point then, did you continue this kind of work, or did you get into other work with the spinal cord injuries?
Oh yeah, as soon as, the vaccine was rather an interesting coincidence, because polio accelerated markedly between 48 and 55, and Southern California had increasing epidemics almost every year, and they have 300 to 500 people a year. They had several thousand people in all. But then the vaccine stopped it just as it was getting worse, and then it stopped it. And which is great, but then you had this backlog. But this also, we'd learned during this period of time the basic principles of both rehabilitation and reconstruction. So polio provided a great service to a lot of other people. Then obviously there are all these other people that need it: spinal cord injury, and stroke, and arthritis, and various children's problems. So we immediately started trying to bring some of the others in, and so we started a non-polio unit in the 400 building, and had a miscellaneous spinal injury and stroke and arthritis, but mostly spinal injury, because no one knew what to do with a spinal cord injury patient, really. And they had programs on the VA, obviously, but the VA didn't have the same intense rehab experience that we'd had with polio, and so that the two systems really hadn't quite jived as well. And so we, in the civilian life, there wasn't any organized thing for spinal injury. They just rattled around in the hospital because they'd have a problem. If they weren't turned well enough, they get pressure sores, and then that's for plastic surgeons. If they got deformities, that was for orthopedists. If they got urinary tract infection, that was for urologists. And no one really was in a position to put the act together. And so the patient just sort of float from one to another. And the county hospital-wide, there was even less organization. And so that we took them on. Vernon Nickel, that's one of his main efforts. He'd say, well, there was 100 down there floating around on these different patients, because he didn't really get them to a good state where they could get home, and yet, didn't have a really good program for them either, so they came here. And that's turned out to be the major need in Southern California, and so that quickly became our next biggest program, and has been our biggest program for a long time as polio disappeared. Interesting enough, we had enough polio backlog that for the first year after the vaccine, we of course expected polio to disappear overnight, sort of like a snowstorm had turned off, and that wasn't true. Why, we didn't admit anybody for one summer because we had all our beds were full with respiratory patients. We had enough reconstructive surgery to do on that group. It took about a year to get them out of respirators and home and these things. And so we had about a 3-year overlap where we got the polio patients all taken care of as much as you could, surgically and medically, and then they went out to the community, and then you lost them. They were able to take care of themselves, or had good intelligence, and good control, and away they went. And you'd see a few for braces, but they'd go whatever was close. So then we started pushing the other, and we started out with a common ward, and then that quickly became not enough space, and so then in 1961 we divided into 3 services. In the meantime, Alice Garrett had joined us, and so we had a spinal cord injury service, and a stroke service, and an arthritis service, and the polios were still there, very much there. And we had an adult polio and a children's polio service. So in addition to the polio, which persisted in the 500 area, we had 600 area. We took over 3 wards and made stroke and spinal injury. And
was that the beginning of these as separate departments?
Yes.
And you had different doctors and so forth for each one?
That's when we started our clinical category to its organization in 1961. And Vernon Nickel took spinal injury, of course he'd always been most interested in it. Alice Garrett was particularly interested in arthritic, so she took them and the children. And then I kept the adult polios and took on the stroke patients. And Los Angeles County being so large, and there really was no other rehab facilities at that time, except a small program at Cedars-Sinai, I think. Why, that we had lots of patients. And of course, these were... So we had at that time, it was very interesting, the patients were almost all welfare patients, typical, medical indigent, not necessarily social indigent. And but then we started, and if we wanted to bring a patient who had resources, why, the referring doctor would have to write a letter saying there weren't adequate facilities in the community, which would be true. and that, but it took that much. So now we're seeking it, but in that time you had to get permission to bring them into the county hospital, and then of course they had to have a pretty dire problem to even be willing to go into a county hospital. But we had a good enough program that they were willing to come.
So it was beginning to be known for its rehabilitation
Yeah.
and working in these
Right.
special areas by
Right.
the early 60s.
Well, it's even, polio was always separate, but even in the early 60s, we'd start getting spinal cord injury patients and occasional stroke patients from outside the indigent population. Because they just, and then you get, in the children's program, you'd get some cerebral palsy that was less often referred because they have a pretty good program here. But you just get a miscellaneous kind of, and these unusual, these severe problems, because basically the standard community is established to take care of short-term problems. And the long-term, complicated ones, and one of the things we have worked very hard to do, and people still comment, is that we made it possible to do everything here. So people didn't have to go shopping around town to find an orthosis there, and a respirator there, and a wheelchair there. And so we've always developed a system, and our therapists always became expert in evaluating the patients for equipment needs as well as just their own direct therapy. Another major change we made in the patient care is in the idea of delegating responsibility to the allied health professionals. Basically, the doctor's in charge of everything and dictates everything. That's fine when it comes to... And the doctors certainly are the connoisseurs of pathology and medicine and surgery. There's just no doubt about it. And they're the best ones to put the picture together, I think, because of their approach and their training. But the details of what this wheelchair versus that wheelchair, or the details of physical therapy, or the best way to handle the hands in occupational therapy, or the details of speech pathology, have been developed by other people, now called allied health professionals. And so that we felt that, one, they had a base of knowledge that should be tapped, besides just their ability to move on command. And secondly, we felt that they should assume some responsibility for what they did. They couldn't go off scot-free. And so we said, all right, if we as surgeons have to account for what we do, you as therapists have to account for what you do. And so we would have them not only plan their evaluation, but make their treatment plans, and then be able to defend their plans and be able to defend their progress or lack of progress in rounds, which is really quite a unique situation. It's because they weren't used to defending themselves. They were used to doing. They never told them it was good or bad, and so that approach is sort of revolutionized the approach of the allied health people.
When you say in rounds, you got together and you...
Well, you see, we either bedside or in conference, either one. But now it's standard team. So I think we really started the team approach. We didn't write about it, so other people wrote about it, and they get the credit in the literature. But we didn't. Well, we didn't write. We were terribly busy. We always had large volumes, and so writing, we just wrote about some critical things. And then I think we actually probably wrote mostly just about surgery because we were surgeons. And the organizational mechanics just seemed something you did to survive. And I'm sure that one of the reasons we delegated because we were busy and we needed help. And here these therapists have good minds, and they have a basic knowledge that we just need to tap. And we wanted to tap it not just on a technical basis. We wanted to tap it on an intellectual basis.
Sure. And
that, of course, stimulates them even farther because there are a lot of good minds.
Now, when was this that all of this happened? Was this after the splitting off of the different departments?
Well, no, we were doing that. We were doing that early. They were team rounds before I came. Vernon Nickel got it started, and I just pushed it, and I think expanded it probably. Mm-hmm. Yeah. It's amazing. He and I had very different backgrounds. Many people could say, that we pushed the therapist because I was a therapist and I had an inflated idea what therapists could do. But he came from a traditional orthopedic background, in Campbell's Clinic in Memphis, which is traditional in the South, the dominant surgeon, and he had the same philosophy. And the delegation, even like to attendance, was developed during World War II as out of necessity. You just don't have enough top executives, so you start calling on the middle management and developing a middle management from your technical group, and you find out they're great. And that's, of course, now standard in many areas. But it's still not standard in all. The physiatrists don't quite, well, there's a large group of them don't quite believe that, because if they couldn't dictate the therapist, then they don't have a role. Because I always say that, they're doctors, you have to practice medicine, and you don't take an MD to direct another group. But in Europe, the doctors still dictate to the therapists. But then they have a surplus of doctors too, because it's a prestigious thing. But actually, this much raises the care of the patient, because then you've got people responsible for the details. Because now I personally would probably be very interested in the details of exercises because of my own interest in muscle function. But the average orthopedist is not interested in the details of exercise. He just wants it exercised. The basic rules are: you identify the pathology as a physician, you identify what precautions need to be taken, and you identify the direction the therapy can take, and then you say work out the details.
Certainly.
And you delegate it, but you delegate the responsibility, because if the details aren't right, it's their responsibility, not mine. And that's the change, you see. You might have them work it out, but if it's wrong, it's my fault that I didn't tell them, kind of thing. Well, that doesn't hold in this place. If they didn't work out the right things, it's their responsibility. And that was the new wrinkle. And that did two things for us. First of all, it got us more minds working at a higher plane. And secondly, it weeded out the incompetent, because they couldn't stand the pressure of exposure of their thinking. They didn't want to account for themselves. They just want to do their little thing. There are a lot of people in the world that just like to do their thing but don't want to be responsible for it. Well, they want to be embarrassed. So they left, which is great.
Well, it seems to have worked.
Yeah. We have an outstanding group, and always have had. And we have a lot of change because, people have many reasons for leaving. The husbands and school and families, and we have a lot of rotation, but we keep attracting a very competent group. And so that, we're the original, I'm the only member of the original group that's still here. And everyone expected the place to close when first Shannon Stoffer left, then Mooney left, and Alice Garrett left, and I guess she was first. And then when Vernon Nickel left, they knew it was going to close. And they'd say, "How's Ranch doing?" I said, "It's great. We got a whole generation." Because the other thing that we did, and again, I guess it was because we had the opportunity because we were large. We had the opportunity because we had our own interests. That we always encouraged younger staff to develop leadership capability, to become in charge. And we always kept developing. So, for instance, we had 3 programs: spinal injury, stroke, and arthritis. I mentioned. Well, when Vernon Nickel attracted Shannon Stoffer, and Shannon was around 2 or 3 years, then either he was going to leave or you gave him the program. So you gave him the spinal injury program, and Vernon moved to something else. And you just kept, developing some new program. And so, and I did the same thing with stroke. When Bert Mooney was in here 2 or 3 years, well, you can only stand to be an assistant 2 or 3 years. And once you get out of your insecurities of your residency and know what you're really doing, well, then these people are all capable of making decisions, or they wouldn't have been surgeons. And so you get out of their way, so you turn it over to them.
So then you moved on to
So you move on to something else. You just sort of keep, and on that basis, why we had a very competent group, and we tried to keep just enough of them that we had a good nucleus, so that when the second group left, why we really have a third generation. And Bob Waters is now a chief of surgery. He's running a superb program.
Tell me, I was going to ask you later in the interview anyway about Dr. Stoffer and Dr. Mooney. Since their names have come up now, I don't have very much information on either of them.
Well, they both had to be from the University of Pittsburgh orthopedic program, and they obviously want to do something a little different. And Vernon, one of the things that Vernon Nickel and Mozart and I do a lot travel quite a bit and giving talks, and you're visiting professor here and there, and people get interested in this kind of project and they want to come as a fellow. And so Shannon Stauffer was interested in the spine, so he came as a fellow in the spinal injury service. And then he stuck around because we needed the help. He was interested in it and liked California. And Bert Mooney came out just because he wanted to do something different. And he about died when he got the stroke service. Because he didn't think, orthopedics don't think much about strokes, but then we showed him it was a very interesting surgical program, and any paralytic program was interesting. And there were things we could do and help. And he became a very strong leader in that for a long time, and then he moved over towards the amputees and problem fractures, and I think I took a stroke back at that time. But these were, fully trained, competent orthopedic surgeons who wanted to do something besides mainstream medicine. And then the other thing we've done, you see, which I think is extremely important for Rancho, is that all our surgeons, in fact almost all our staff, except some of the internists, all the surgeons are part-time. And this is good because orthopedic surgery is a very dynamic specialty, and the people that go into it are movers and doers, and so they keep up. So they keep that part of themselves active, and they keep current by their private practice, and then they spend part of their time instead of spending all in private practice, which also can get routine after a while because you just only so many kinds of fractures and so many kinds of hips. And so if you have sort of a creative mind, then you'd like to do something in addition, and so then they would come here, and they'd be here roughly half time. And this was good. So it was a nice blend because things don't move that rapidly in rehab. And it's not an acute thing you're going to change in a week. You're going to change it over 3 months or something like that, or maybe longer than that. And the changes you make will be smaller. And so it's a nice blend of the intense and the more sophisticated.
Now, I had something on Mooney that carbon implants and lightweight prostheses and things of that nature that he developed. Yes,
he got very interested in prosthetics, and he was very interested in improving the prosthetics for the elderly. See, the original prosthetic field was designed for the war wounded, which were young, vigorous people. And you're diabetic now, your primary amputee is an elderly person who's lost her limb because of circulation, and most of them because of diabetes. And that's a group of people who cannot be strengthened. They don't have the circulation to strengthen their muscles. And so they're never going to be vigorous. And so he was very interested in getting something lighter weight until he developed, and then so lightweight prosthesis in one area, and then the temporary prosthesis, which is an adjustable prosthesis, not necessarily so temporary. It started out temporary, but it's not temporary anymore. It's just a light plastic polyethylene socket in which you can pull it together with Velcro straps, and you can change its size, because these people change size. They swell a little bit, and they shrink a little bit, and they get fat, and then they get thin, and so they can just adjust that, and it's much lighter weight than the standard. So those are two areas. And then he was very interested in electrical control of the paralyzed arm, or in fact, he was interested in electrical control using the normal muscles, residual muscles, to control prostheses. And so the question is how to make your connections, and so he tried to make through the skin connection and had a variety of. And carbon's a very inert metal element that will transmit electricity, but also is inert to the skin, and so they tried a variety of implants. Unfortunately, the skin didn't agree to it, and the biggest problem is that any of these things you made are rigid, and the skin's very mobile, and so the scar where you join them would break, and so it didn't turn out to be a realistic thing, but it went on for a long time, and it taught us a great deal about skin tolerances and what we could do. And essentially told us we better use radio frequency underneath, but
So he was just here a few years then?
Yeah, I think he was there about, Shannon was here 12 years, and so was Alice. I think he was here about 10 years, so quite a few years. He left, I'm sorry to tell you when he really left. He left only about maybe 5 years ago or something like that. He's down at Dallas now, chairman of the department. Well, see, Yeah, it'll be about that time.
I wanted to ask you about scoliosis too.
Mm-hmm.
I know you've done a lot of work in.
Yeah, that was my original major surgical effort.
I see. Did you start that back with the polio patients? Or?
Yes, do it. A spine is a whole bunch of little wooden, bony blocks with discs in between, and it's very flexible, and it'll just fall sort of any old way if you don't have some muscles to keep it together. And if you have paralysis of the trunk muscles, why these people just fall in terribly curved posture, and they get fixed deformities after a while, and then they reduce their breathing capacity, lose their ability to use their arms well, and all these other things, walk, and so we again, we did not invent spine fusions. As I mentioned, they started in small segments, started in 1911, and then they extended it. What we did do is we did three things. One is we developed the halo, which it said we can control the head and neck, which actually we designed because we had a lot of paralyzed necks, and the heads would fall down this way or way like this, and you wanted them up, decent position. You had to hold the head. Secondly, we modified casting techniques and surgical management so that we could operate on these severely paralyzed people and not interfere with their breathing. And then we used a very careful subcutaneous dissection so we would minimize the bleeding, and so we could do long fusions, because we fused. I actually have one person that's fused from the skull to the sacrum, but usually all the others had a couple of segments above or below. So we did very long fusions compared to anyone else. So we did them for stability. And the other thing we did is recognize that the curve, usually a spine curves three ways. You have this major curve this way, and then so in other words, if you lean over this way, you bring your head back, and the spine does it within itself, not necessarily the head. And so that if a person has a primary deformity in a normally innervated, normal person who just develops a spine lesion, then you can just treat that major segment, and the rest of it takes care of itself. But if you use that same technique for a paralyzed person, the rest of it can't take care of itself. So it just falls over. And so what we had to do was fuse the entire paralytic segment, and that's what got us doing these long fusions rather than treating just the primary curve. And then we started doing what we call osteotomies, which if you had a fixed deformity and they're all falling off to the side, we'd actually remove a wedge of bone of their spinal canal, or their spinal column, and straighten them out. And then in order to control the deformity, we used wires that were fastened around a button in the spine, and to pull them over, and had elaborate frames to make these corrections so they could see. Most corrections were made by putting a person in a cast and prying over the cast. Well, we couldn't do that because we couldn't pry on their chest because they couldn't breathe, so we put wires on the spines directly. And one of the many things we didn't write up very much, and so somebody recently redesigned that. Called me, they said they found this one little article on about it, and they designed the same thing.
So, some of these, though, were, even though they had been established early, it seems like you elaborated on it.
Yeah, that's right. We've elaborated the technique and applied it to the more severely disabled, the more severely deformed. We could take by long curves, by long fusions, we could handle more deformities. By our buttons and wires, we could get better correction. And then by our osteotomies, we could get better correction.
So the buttons and wires and all that was some of the new, new techniques.
That's right. The buttons and wires were new. That was us.
And when you say you and you say we, who were the we?
Well, I'm the button and wire person. I did 90% of the spine work. I was a spine surgeon here. Vernon Nickel got it, started, but he really didn't do much surgery after I came because he was in private practice, and I was here full time. And then I persisted with the polios, actually until 1968, and then I had a medical problem that took me out of surgery. But I'd done at least 300 long fusions by then.
Were you putting the rods in later on, doing that?
Yeah, when Harrington brought the rods in, well, that was obviously a very nice answer. And so we were one of his staunchest supporters for rods. And in fact, we taught him to use a spine fusion along with the rods. He really wanted to do the rods without a fusion when he found it didn't work. And then he was doing sort of scratchy fusion, so then we pushed him to do a better fusion. And then we got him to go up with John Moe was probably the leader of techniques in fusion. He's a very dynamic person, so we got him to go up and learn from him, and as well as prodding.
So Harrington was the...
Harrington developed the rods.
And he was a surgeon.
He's a surgeon. He's an orthopedic surgeon from Houston.
And he brought them here to you?
Yes, he... It was heresy to put these rods in. The casts, he did correction with casts, and people just thought that was terrible. And he didn't have all these casts, he did rods and stuff. And his original thesis was wrong, because he wanted to just put the rod in and jack it up every so often. Well, bone doesn't take that, because bone is not a piece of wood. Bone is living tissue, and it molds, and if it gets too much pressure, it erodes around that pressure. And so that the rods would come loose, and also metal can't take infinite bending. If you want to break if you have a wire and you want to have scissors, you just bend it back and forth and it'll break. Well, that's called a fatigue fracture. Well, a rod that big will also fatigue. Your car, that's what happens to cars when an axle breaks. It is the rod, you get a fatigue fracture, you see. And the same idea. Well, that applied in the back too, and the rods would break. If they didn't cut out, they'd break. And so that principle is wrong. But the idea of having a jack within the spine that you could hold these people up around all these massive casts that were pushing people around and making pressure sores and weren't working too well, because you couldn't keep them in the cast as long as you'd like to keep that rod, was a great idea. So if you look past the foolish part and looked at the basic contribution, it was very great. And he'd done a lot of very careful research ahead of time on the mechanisms of scoliosis. And actually, what I learned from Vernon, didn't really realize it when he first came out and made his presentation, there was so much antagonism to his approach that National Foundation, Polio Foundation, which had been supporting him, was in questioning whether they should continue their support. And we essentially reviewed his work as to whether it would be good or bad. And we gave him, a strong vote of confidence with some modifications to add a fusion too, because so we looked at it as a means of getting a correction and then holding your correction while the bone stabilized itself. And that you really weren't going to maintain a flexible spine because that wasn't appropriate. And once that approach was taken, why, then it was a very good technique. Now, of course, there are 3 or 4 other systems. Oh, there's a variety of systems now. Dwyer came out with a cable that you put in the chest and on the front side and pulled it straight. And Lukey has a rod which has a bunch of, looks like a coat hanger, a bunch of tree, like a tie tree with a bunch of crossbars that you wire together. And Dunn has another, those are 3 additional systems I know of. They come out, and then there's some of the guys who got some not pins, were just for little segments, and so there's a bunch of things that come out. But the other history is that in England they tried to put plates on the spine to hold fractures, while the bone they put them on was too thin, and the system was inadequate, so those broke out, you see. And these are things you really can't test on animals because they don't do the same thing, and so you just have to rationalize them and then try them. And the justification of trying is what you have now, so bad, most anything is better, kind of thing. And that's sort of the way you make your progress. And so we did a lot of spine work, and we still have a spine program, but it's much smaller. Dr. Swank runs it now, because there's still people that are deformed both by paralysis. There's spontaneous loss of muscles called progressive muscular atrophy, which is a childhood disease. Their nervous system just doesn't mature adequately. And then there's scoliosis. There's cerebral palsy causes crooked spines, and muscular dystrophy causes loss of muscle and crooked spines. And then there's what we call an idiopathic scoliosis, which really is, it's idiopathic. We don't really know the cause, although it's pretty obvious it's now a developmental and an inherited developmental error, and to some extent runs in families. And now that we're catching it early, in fact, even the screening program started here with, I lost the man's name. It got its greatest emphasis in Milwaukee, but we got the screening program started here, looking for curves very early, and that's the main way the crooked backs are handled now. They're picked up when because it's become evident that it's about the 5th grader, 6th grader, who starts to get this, when they get this secondary growth spurt, has an error in their growth mechanics, and their spine will start growing crooked. If you can catch it very early, well, then you can stop it becoming bad.
Are they going into the schools and screening them there and then referring?
They have major school screening programs throughout this nation now.
I'd heard something about that
Yeah.
recently. So I have you in the stroke, head of the stroke unit department. And then from that point, I'm not clear on what you did.
Well, I've had 3 medical problems. And let's see, I guess the significant, well, 67 I got a major disc, but that just interrupted things for a while, and I went back to surgery. But then in 68, actually as an outgrowth of this disc from a lot of posturing, I managed to kink a vertebral artery, and I discovered then I have a congenitally small left vertebral artery with an inadequate circulation in my brain, and so when I kinked that, I gave myself a brainstem lesion, and I just got terribly, terribly dizzy if I moved my head, because my dizzy center got disturbed. And so I had to give up surgery. Don't tell anyone, but I really didn't mind. I didn't mind giving up this spine work, because I was just, by that time, it was manual labor. I'd done some 300 or this long, and just worked 6-hour surgeries, and just getting tired of it. But I sort of missed giving up the hand stuff, because it's the reconstructive stuff of hands and feet and muscle tendons are fun. But really, I really am not a dedicated surgical technician. I did surgery in order to accomplish something. And I like to work with my hands. I'm a carpenter at heart and that kind of stuff. But I really mostly interested in muscle function, and so when I couldn't operate anymore, I just started this lab. And I've, there's a surgical crew here. The surgeons will work very well with me, and they'll sort of do anything I ask them to do, because I can explain the mechanical logic to it. So I have no problem getting operated when I want to operate.
So that was the beginning of this department then?
Yeah.
You started this then in 68?
Well, I started my first research in 1961 on hand muscles. And I got an NIH grant to buy some equipment and study these. And I did that for about 6 years on an intermittent basis. I would just steal Tuesday afternoons and just tell people I wasn't here. And but then in 67 I had this disc, and I couldn't operate for several months until I gave me some time to sort of clean up that act. And then I got this started. We needed more space. And the reason that I started this laboratory, the first research was just to find out the patterns of muscle function, and so we could, reconstruction of the hand would be functioning more logical, because some muscles, our brain makes some muscles work together automatically and turns some on and some off. In other words, this group works when you want to open your hand, and this group works when you close it, and there's certain cooperation between the wrist and the hand, and if you can stay within those natural synergies, why then some people just move because they're born they can move, and there are others who are professional athletes. But there's some people who are just not athletes, just oafs no matter how much they try. And I call them sort of motor morons, and then there's a motor athlete. And so it'd be wrong to do an out-of-phase transfer on the motor moron who just doesn't know how his muscles move. And so you want to, and so that was the purpose of original research. But then the second research, the other thing I want to do is document what we accomplished with the rehab, because we're not making people normal. We're improving them. And then the question is, how much have you improved them, and have you really improved them? And so I wanted to document that, and that's what really started this laboratory. And then from that, when we started our EMG, and then we discovered that could be a diagnostic tool as well as just a follow-up tool. And so,
what's EMG?
Oh, I'll tell you.
Okay.
It's electromyography, and what it amounts to is that when a muscle is activated, there's electrical signals sent through the muscle that tells it to work. And we can record those signals. And that can tell us when a muscle is working, and give us an indication of how intensely it's working compared to its manual muscle tests we use clinically. Mm-hmm. Now, in stroke patients, in cerebral palsy, in head trauma or spinal cord injury, these people have lost their control of their muscles, but their muscle system is normal. So what it amounts to that there are two nervous systems in the body. There's a peripheral nervous system and a central nervous system. And the central nervous system is the brain and spinal cord. And then starting in the anterior horns of the periphery, in the spinal cord also starts the peripheral system, so that the spinal cord is a junction. So the brain is the control system and a bunch of other centers in the brain, coming down within the spinal cord, and then from the spinal cord you get these nerves going out to the muscles. And so you have the peripheral activating system and the central control system. Well, in polio, you ruin the peripheral system, so they don't have the muscles, but they got perfect control. In these spastic patients, which I just listed, the spinal cord injury, they have normal muscular system, the peripheral system, but they don't have the control. And so surgically you can improve those people by rearranging, either releasing or moving a muscle that's working inappropriately. And so that, but the question is, not all the muscles are working inappropriately, and when are they working inappropriately, and which ones? And trying to diagnose that is very difficult with standard clinical tools, because every time you change the position of the body to isolate something, you also change the neural input, and you have two variables, and so you change your response. So we set up a system to record the muscle activity, and again, this was not new. EMG had been done by others, but we just used it for a different purpose and refined the system, and now it's a major pre-surgical diagnostic approach. So that our surgeons, when they basically take a cerebral palsy child, you see the child, his foot is crooked, goes crooked every time he walks. You examine him, and you say, this is a muscle problem, not a bone problem. If it's a bone problem, I get x-rays and do bone work. If it's a muscle problem, so then you send him pathophysiology, record the exact pattern the muscles are working, and say, this is the kind of surgery I'll do. So there's sort of 3 steps. 1, identify this problem. 2, that it needs surgery. And 3, then you get a test over here to find out the exact technique, and then refine the technique and do it according to the final results.
Sounds like kind of the same thing you were describing with the hand, where you put the muscles here and there.
That's right. You're doing the same thing. You're moving muscles here and there, and it can be in the hand, it can be in the foot, or the elbow, or the shoulder.
Anywhere now.
And so we just have a system putting fine muscles in, and fine wires into muscles, recording the signals, and I can show you that.
So I was going to ask you if you would define pathokinesiology for me.
Okay, well, kinesiology, kines means motion, and ology means study or philosophy or what have you, and patho means pathological motion. So the kinesiology is an old word. So all we ever do is modify everything. But, and we used to, initially called it kinesiology. I didn't want to call it biomechanics. I wasn't interested in just the mechanics of motion and the forces. I wanted to know essentially the physiology of the motion. So I was. But then the physical education people decided to be kinesiologists because universities weren't supporting education programs. State colleges did that. So they had to be more academic, so then became kinesiologists. So then they stole that word, and I wasn't dealing with normal people, so then I modified to pathokinesiology. So now it's become an established word, and it's used by therapists all over, and other people use it in their literature, and so I contributed to Webster's. I'm not sure it's gotten there yet.
So that would translate then into the sports medicine that Dr. Barrett, somehow the studies that you're doing. Yeah,
well, I got Sentinel. They call themselves biomechanics, and that's all right. And most people do, but there's sort of the 2 words are being used now. And they do it, but their laboratory is very much like this laboratory. In fact, we helped them develop it. And Frank Jobe, I don't know how much you follow the pitchers in baseball, but he's very well known for his surgical improvement of pitchers' shoulders and elbows. He's a shoulder and elbow surgeon, really. He's just excellent. He's a man that was trained here. He's a county hospital resident and came here for 9 months. And so he's one of our residents way back about 25 years ago. And he wanted a laboratory because he wanted to find what's happening in the athlete. And so I helped him set one up. And I go out there regularly on Mondays and consult with him.
Interesting. Yeah. Now I know you teach classes now. Have you been doing this all along, or work with students
Well, on a formal, well, informally, yes, always. For instance, we've had, for our own residents, we've had surgical anatomy since probably 1957 or something like that. We used to go down to the White Memorial Hospital where they had an anatomy facility, and we'd go down there Monday mornings and meet. And we finally got our own here. We've had one here for since ever they built that medical science building. We've had one here. In fact, that medical science building got built because I wanted a place to have anatomy. I quite have the smallest room in the whole place, but I started.
Good.
And because we wanted a place to have cadavers that we could both ventilate and lock up, and there wasn't any place in Rancho to do that. So that was the stimulus for us. And that's the only research building the county's ever built. And then they put it all together and brought they had a lot of things going on these old buildings, and so they brought them all together in that building, the respiratory, the cardiac, photography put together. But that started from that need, and John F. was clever enough to use it to. So in this case, it reversed it. Well, one of an the war was lost. This was because of one of an the building was built. The war was won.
Good.
And then we, in the meantime, this place was available because this really was a custodial, post-rehabilitation custodial ward. At one time it was mental health. That's why you see those funny little windows. And then, of course, mental health moved out to nursing homes. And they decided senility was no longer a mental disease. And that was a big breakthrough for a lot of people, of course. They just put them in standard nursing homes and got them out of these places. And then with Medi-Cal and AMA or MMA or whatever it was, medical aid to the aged, that was at MAA, was the first program that preceded Medi-Cal and Medicare. Why now you have funding, they don't have to be in county facilities and have much better funding. Because you have least money for things from a county tax because the people are too close and they're too critical and they don't want to pay for anything. And so and that's why things are better funded in state or federal than locally. The local people, somehow they see all the negative sides and not the good things. If it's far away, they see the good things.
Well, so do you have students now, or do you lecture to students?
Well, we still have the surgical. Actually, I've turned most of the surgical anatomy over to the surgeons because I don't operate anymore. And but I meet with the residents every week, every Wednesday, to discuss muscle function on the people on the stroke side. And then I'm part of the faculty of the USC PT school, one of their professors. And so I have a formal class, which on Saturday mornings, the only time I could find. So from 7:30 to 10 on Saturday mornings, I have a class, again, which relates to muscle function. And then in the fall, we call that analytical kinesiology. And then in the spring, I have a course on gait analysis. So I've been 3 different activities: Sentinella, USC, and Rancho.
Gracious me. 6 days a week?
Yeah.
Oh, dear. I wanted to ask you if you had any personal memories or anything about any special people or times.
Well, I don't know.
Patients that were different or cases that were really unusual.
Oh, they're all unusual. The whole focus. No, I don't. I guess I bury myself in my patients, but I don't really make close friendship or specialty kind of things. I just like the whole world, like whole work. And do you know?
So many probably in there.
Yeah. We were doing spine fusion 3 times a week. They're all exciting. You're great. I suppose the greatest triumphs were twofold. Either you got them back, like Emma Veris, I tell her name, but went on and got a PhD in Spanish.
Ivers. Emma Ivers.
Well, that wasn't her first. That's her married name. She has another name.
I don't know.
Emma Shaw, and that's not yes, another Emma. Anyhow, she's doing what she can do because I fused her spine.
Mm.
She's a wet noodle and deformed, and now she's ambulatory and fully independent. And I've got quite a few of those. Richard Daggert's doing what he can do because I fused his spine. He's president of the local Polio Foundation. Goodness gracious, who's the guy that's in the volunteers now? Jerry. What's his last name? you know, fused his spine, and he's up sitting in a chair, and we've got a whole bunch of people that.
That must be very satisfying.
Oh yeah, it is. And you know, people that use their necks and they're back to productive work, like the Erics. But I haven't made a point of keeping track of people. I just keep moving on from one to the next. They come back. They come back when they have a problem, or once in a while they come back for some other reason. But I just keep moving from one thing to the next.
Let me ask us about Viola Robbins.
Oh, Robbie. Oh, she's wonderful. She was here when I came. She and Addie. And Robbie was just buried in treating patients. We had a very non-productive head of physical therapy at that time that sort of buried herself in it. We had a little standard PT program for the Rancho people in addition to polio, and Robbie's with polios. And so we twisted her arm to become head of the PT department. It had to grow, and she was very capable of doing it. We finally convinced her to do it on the basis she could treat more patients if she was charged than if she... So that we convinced her to be head of the department. Vernon Nickel and I both worked on her, and she did. And she just was excellent because she's a superb clinician. She understood people, and she was a good organizer. Actually, she was General Eisenhower's secretary in World War II over there in ETO. And so she had she was her secretarial background, and after World War II she became a therapist, so she just sort of got into the end of it. But she was just an excellent person, and she vanished. But finally she decided to retire, and the reason she retired is she didn't keep up. Now don't tell me else this, but I don't know how you say that. But she was here for 25, whatever it takes to retire. She was here. I guess it must have been 20 years when you retired. And hit 55, but she hadn't kept up clinically. She was a superb administrator, but you just, if you're an excellent organizer, you can organize it so everyone else is doing the work. Mm-hmm. And pretty soon you don't have a job. Unless you develop side interests. Mm-hmm. And she didn't develop professional interests. She developed personal interests. And so it was time to move on from it, so that she really did not become, in the meantime, you see, clinical work had moved away from polio into spinal injury and stroke, and she really was not an academician. Mm. She was just a fine person and an excellent organizer, but not really a natural student, so that she didn't keep studying, new things. And so I think that's why that's my interpretation why she retired. That's just my own. But and so she just got so organized that they didn't need her. Actually, they did, but...
move on to other things.
Yeah, so she moved on, and she unfortunately had an auto accident.
Yes, I know. It's so sad. I'll ask you if something comes up that you need to talk to me about, too, that you think of later on. I can come back, and then I'll ask you about Dr. Nickel and a couple other people. Okay. But I was just going to ask you to sum up, and I like to use pieces of these in quotes. What if you had to describe your time at Rancho, 3 years here at Rancho, and your work to someone? How would you describe it?
Well, I always have a hard time doing that. I don't know how. I told you I spent an hour and a half talking. I don't know how to do it in 2 words. Well, it's just been it's been expensive. Rancho was built for me.
That's it. You don't want to elaborate on that, do you?
Well, it has exactly the things I wanted to do. It was patient care, and it was creative things, reconstructive surgery, involved therapy. It just everything I like to do.
Sounds like it's been ideal. Okay.